Morning, everyone. My name is Tim Bannock. I have a few items just to quickly go over before we get started with the presentation today. Directly after the presentation, there will be a quick poll question that must be answered to receive your CEU certificate of completion. The handouts for the webinar are also located in the handouts section, which is located on the control panel for GoToWebinar. So if you have minimized that, if you actually bring that back out, there's a handouts section. You can directly download the PDF version if you want to follow along with Steve today. Also, if you're interested, there is, always go check us out, qliomaha.com for more information about us. And then during the webinar, please feel free to ask questions. We'll make sure to get those over to Steve to answer. If appropriate, he will answer them during the presentation or during the Q&A time at the end. So first off, also thank you for joining us this morning. I don't know, Steve and I we were almost stuck in Minneapolis last night. The Midwest got hit pretty hard with the snowstorm, so we made the trek through the snow last night from Minneapolis to Omaha. So we wanted to make sure we bring this content to you. So I have the pleasure of introducing Steve Kershke. For those of you who do not know, QLI is a unique and specialized post-hospital rehab provider for individuals who have suffered traumatic brain injuries, spinal cord injuries, and chronic pain. Steve Kershke completed both his undergraduate degree in exercise science and his master's degree in physical therapy. He joined the clinical team at QLI in 2005, and in 2010 was promoted to serve as the Director of Therapy Services. In that role, he was responsible for coordinating all therapy services at QLI, as well as leading the spinal cord injury team. At that time, he also oversaw the development and implementation of QLI's unique functional restoration detox program. Steve now serves as the Director of Marketing and guides the execution and strategy for QLI's national marketing efforts. This involves developing relationships in the work comp industry, presenting nationally, and ensuring payer partners' engagement with QLI is efficient, effective, and achieves successful outcomes. With all that said, I'll go ahead and slide over and hand the mic to Steve.
Thank you, Tim. Tim and I were joking, for those of you who signed on and maybe saw the old school photo of me, there's some extra credit in there if you can figure out how old I was in comparison to the photo you see at the very end. So if I'd have known that they were going to show that photo today, I might have given a little bit more hard time about participating. So obviously we're talking about telerehab today, and from the way we stay in touch with our current events, all the way to how we dial up transportation in a new city. The other day, as Tim mentioned, we were in Minneapolis, and it was pretty quick and easy to dial up an Uber or a Lyft to get where we're going. And so certainly technology has created a fundamental shift in how we think and how we act. And of course, over the last century, this is seen in all industries, and especially in healthcare. So this includes telerehab, and I think telerehab has the potential to optimize our conventional practice, but also revolutionize how we deliver services. And certainly this is something that QLI is investing in currently, and in a lot of ways we're just beefing up what we've done, especially from discharge and transition services, but we're actively exploring ways to integrate telerehab into our everyday. So this is an exciting topic for us, and hopefully you all enjoy the presentation today. So before we dive in too far, I want to make sure we're all speaking the same language. And so telemedicine is, as you see on the screen, remote diagnosis and treatment by means of telecommunications technology. And so telemedicine and this next one, telehealth, are very much umbrella terms, and they are an overarching term to describe the delivery of services essentially through technology and video technology. To dial it in a little bit further, what we're talking about today is telerehab, and so this is the delivery of conventional therapy services at a distance using telecommunications technology. So it's just another level or two below, and if you really want to get more specific, you can call it teletherapy, telespeech therapy, telephysical therapy, and those are really just more descriptive terms. But for the sake of today's presentation, we are going to be referring to it as telerehab or telerehabilitation. A couple other terms to be mindful of is asynchronous versus synchronous. Asynchronous technology is also known as store and forward. And really what this means is that the provider and the client or the patient do not have to be real time. They can exchange information and they can view it at their convenience. So an easy non-medical example would be email. So if I typed up an email today, sent it to all of you, and you viewed it at your convenience, that would be an example of asynchronous communication. In the healthcare world, things like X-rays would be an example of asynchronous communication, where the radiologist is able to read the X-ray and then send it over to the physician also to interpret the X-ray, and they don't have to be in the same room or view it at the same time. On the flip side, synchronous communication is a real-time encounter, and that's really what we're going to be talking about today. It's the use of video conferencing technology in lieu of a personal visit, and so it avoids the need to go to an actual brick and mortar building to visit a physician, or in this case a clinician, and it happens real time. An example would be FaceTime. So if you have family or friends or grandkids that you like to video call with over FaceTime, FaceTime is a perfect example of synchronous communication. Remote patient monitoring. This is another example, and really this takes into account the opportunity to track blood pressure, heart rate, respiratory rate. We can track glucose levels, oxygen saturation. There's a whole host of technology that allows this type of information to be tracked remotely. Wearables are a perfect example. So if anyone has a Apple Watch, your Apple Watch tracks your heart rate. It tracks your status during a workout, and so that's an example of how we could use remote patient monitoring. Sleep monitoring is another area that we use it for at QLI today, and so we have folks come in and we track their sleep from day one over a period of time, and we can determine how well or not well that they're sleeping and adjust their schedule and sleep hygiene and protocols related to that. So remote patient monitoring is a nice opportunity, even when someone's in the presence of your building, but certainly an opportunity related to telecommunications. A couple things to talk about as far as benefits of telerehab. And so for us, this really provides an access to expertise and specialty care. So for individuals with neurological injuries, brain injury, spinal cord injury, what we often find is that they're discharging from Omaha to another community, and quite often their access to expertise is limited, or due to the fact that it's just not in their area, or there are clinicians in their area that haven't dealt with these types of injuries, and so their access is limited. The other thing that happens is the continuity of care is disrupted when they transition from facility to facility. This happens even on the front end. So if someone has an injury right out of the gate, they go to an acute rehab hospital, let's say they come to QLI after, that continuity of care, although it is relatively high, still poses some challenges whenever someone transitions. And so when they leave QLI, that's another transition point that can be a challenge. And so the use of telerehab allows the continuity of care to be a bit higher. The contextual training environment is especially important for these populations. And those of you who have tuned into some of our other webinars know that that's something that we talk a lot about. The idea that someone can train in an environment that's as authentic and genuine and as similar to the environment they're going back to is extremely important, especially for folks with brain injury who don't have the ability to problem solve and reason, and they don't have the memory component intact. Having an environment that's as close to the environment they're going back to allows for generalized learning and allows for the building of really solid routines. And And so, the contextual training environment is way more accessible in this situation where we use telerehab. Convenience. This is probably no surprise that this is on there, but there's certainly a reduced travel time and cost to accessing providers. The easy one is, someone living in a rural environment and having to drive, an hour or two to access care. That's pretty obvious. The other situation to think about is even someone who lives near or in a metropolitan city. A lot of times traffic patterns and that sort of thing can make access to providers more challenging or just more inconvenient. And then improved compliance, that's related to that, and the fact that because someone doesn't have to travel or access their environment through transportation and that sort of thing, the compliance is higher. So if they just have to sign on to their phone or their iPad, what we find is they're more apt to show up, and it's just easier to log in and have those interactions with their clinicians. And that relates to accountability and responsibility. What should be happening with these folks at this level of care is that they're taking even more ownership over their therapy, over their life. And so hopefully clinicians are transferring that to them. And in doing so, they take on more accountability and responsibility. And so as you'll see, as far as service delivery, it does require quite a bit more training for the clinicians, as well as planning on the client's part to make sure that sessions go well and go smoothly. On the flip side, there's certainly some challenges that need to be worked out. And some of it is just more because it's unknown and it's new. Telemedicine specific to physicians has been around for quite some time, and even that is still needing some research and outcomes to back it up. Well, telerehabilitation is even more new, and the jury is somewhat still out on that. So quality of care and objectivity is certainly a concern. And while there are ways to do that, there's certainly a place and a time for telerehab and being able to go to a brick and mortar type of facility. And then I alluded to the research and the outcome measures. The research is coming along, but there's still plenty more research to be done. Technology in general, there's certain platforms that are available, but that still has a little bit of ways to go as far as making things streamlined. And then access to technology, and just are folks even savvy with technology? Our younger populations certainly are more savvy to this, and when we use this with our folks who are younger, they really love it because it's something that's just part of their life. For individuals who have not grown up with technology, we have to do quite a bit more training and a little bit more hand-holding to make sure that they can access that. But what we're finding is again, the convenience and the effectiveness is starting to outweigh that piece of things. Wi-Fi and cellular connectivity, certainly in more densely populated areas, this is less of a concern. But having access in rural communities is really a big benefit. And so there's still challenges related to this. That being said, we're seeing a lot of investment at the state and federal level to ensure that there's broadband and cellular service more widely available to these individuals. And so I would assume that this would continue to be more accessible. We're not going to touch on this a lot, but it's worth mentioning that public policy, regulation, and funding are also challenges, especially with Medicaid and Medicare, and how they are approaching this. And some of the challenges related to that have prevented some adoption from a clinical standpoint. So as we go, try to outline a couple ways to determine whether or not you have a good referral. The other thing is, once you have a good referral, the assessment process is going to be extremely important, and then some key aspects to service delivery. So we're going to highlight these three areas as we move forward through this process. A good referral. So there's certainly some considerations. For the sake of this presentation, we're talking about folks who are living at a community level of care. And so if you're considering someone for an outpatient physical therapy clinic, occupational therapy clinic, then this is potentially an opportunity for them to access services in a different way. And so when they're living in the community and it's community based, telerehab poses a really great option because of the mobility and the, again, access to a more authentic environment. We've touched a little bit on the rural versus the metropolitan location. Certainly there's upside to both. The rural, typically the providers available in that area with the level of expertise is nowhere near what you'd find in a metropolitan area. And so it's a really nice option. Or they do have clinicians in that area, and the clinician has maybe worked with one individual with a brain injury or spinal cord injury, and they really could benefit from some consultation and education on best steps for rehab. The metropolitan location, again, a lot of the major cities are going to have a really nice option for these individuals, but it may not be accessible due to traffic. And honestly, when it's cold or even hot for some of our folks with spinal cord injuries, going out into the community can be a bit of a barrier. And so this is a nice alternative option. Some things to remember when you're considering a referral is what is the desired outcome? And that should be something that, regardless of telerehab or a traditional brick and mortar therapy clinic, we should be asking what's the desired outcome goal. And depending on the outcome goal, this could determine whether or not telerehab is or is not a good option. The other thing to consider is what host of disciplines are you going to be accessing? A few options we believe are effective is physical therapy, occupational therapy, speech therapy, and psychology. Going into this, I'll be the first to say that physical therapy was an area that I was a little bit skeptical about as far as how it could be applied via video call. But what we're seeing is it's just as available as OT and speech and psychology. Certainly there's some more barriers, and for someone who needs a lot of hands-on services, it can be more challenging, but it's definitely doable. The OT, speech, and psychology, in my opinion, are no-brainers for this, and are something that again, are a really nice option for many of the folks that we serve. As far as caregivers and clinicians, one other barrier to this is the need for hands-on. And in our situation, we've been leveraging clinicians who maybe don't have the experience that we have, who do happen to be in the area. Students, occupational therapy, speech therapy, and physical therapy students are a really nice option. Even aides who are being paid to be in during ADLs or just support times throughout the day are really nice options. And this goes back to what I initially mentioned about transferring the accountability and responsibility over to the client and their family. If we can train these caregivers to implement a lot of the therapy techniques that we're doing, again, there's less dependent on the clinical aspects of care, and that keeps costs down. It also leads to greater engagement with these individuals and a more sustainable outcome. And so this is really something we should always be considering, but a really nice byproduct of telerehab. As far as other, there's foundational routines and support that need to be in place. If you're thinking of telerehab for someone who really hasn't had a lot of therapy and hasn't had a foundational routine developed, it could potentially be pretty challenging because of the amount of repetition and support that it requires. And so that would maybe be a situation where if you came to us and said, hey, we're thinking about this individual and they didn't have those in place, we might recommend some sort of more intense type of setting, such as an inpatient post-acute program prior to initiating telerehab. So that's just something to consider. As always, we're looking at psychosocial history. Those sorts of things do make it challenging to get a good outcome. So wanting to make sure we have good upfront discussions about that ahead of time and make sure that everything's on the table and we're really upfront about what we think the outcome could be and certain barriers that might be in place. Vocational rehab, this is more of a gray area in my opinion. I think there's some good opportunity to provide vocational rehab in this way. With that being said, for job responsibilities that are more organic and a bit more unpredictable, this can be more of a challenge, and a situation where you might want to enlist a job coach who is actually at the setting and then be more consultative in that fashion might be a better option for that type of job. On the flip side, if you have someone who has a desk job or a very rote type of job, we can do lots of things to impact that and make that individual more successful. So really has to be a case-by-case situation when it comes to voc rehab. As far as the assessment goes, I think what we found is a combination of in-person and virtual assessments are a really nice option to make sure that you're getting a good idea of what the person's environment looks like. And that in-person assessment should include not only their home, but anywhere else in the community that they're going to be accessing. And unless we get a good idea of what that looks like, we cannot develop a really solid and thorough treatment plan. And so right now, just given where technology is at, given the newness of this, an in-person assessment, in my opinion, is pretty crucial. But beyond that, if there's additional disciplines that need to be involved, you can do the rest of those virtually. So as an example, having an occupational therapist out to the person's home could be a really nice in-person assessment, but the PT or the speech therapist could virtually call in, and the rest of those assessments could be done while being facilitated by the person who's there with the client. And so again, this helps determine the disciplines involved. This helps make sure that the goals are very clear and measurable to make sure that we're showing effectiveness. And at the end of it, we should be able to provide a really good idea of how long the therapy is going to last, as far as weeks, and then how many days a week will therapy occur. And so the frequency and the duration of the therapy should absolutely be something we can determine, and also accompanied with very clear therapy goals at the end of the time being served. As far as the technology platform, there's really a couple options that you can consider. There are some full service platforms out there that are providing integration with EHR and calendar invites and management and that sort of thing. And then they have the built-in video technology as part of it. And the flip side would be just accessing simply a video conferencing platform that only has that technology, and the EHR and everything else would be kind of on the periphery. So those are really two options. I think as we've considered that, some of the challenges with the full service platforms is they're really great for some things, but then they don't have other aspects that we need. And so for us, we're utilizing a video conferencing platform only, and determining what other scheduling and tools like that need to be integrated, and utilizing our EHR separately from the platform. Other things to consider with the platform is collaborative tools. So things like screen sharing are extremely important, especially for speech therapy, so that you can see and do some training with iPads and that sort of thing remotely. And so being able to see what the individual is accessing through their internet, or maybe how they're typing in and scheduling appointments and that sort of thing, is really, really important. Whiteboards and collaborative spaces are also available through these platforms. And so again, being able to share and translate different types of information interactively is something to consider. And many of these platforms have them, but some of them don't. So just making sure that you have a really good option for that. Session recording and transcription options is also something that in our minds is really important. It does a couple things. One, it's a tool to provide information on progress or lack thereof. The other thing it can do is provide an opportunity to share and reshare some of the activities that you're doing during therapy. And so it can serve as a nice home exercise tool and a nice opportunity to share that information after a therapy session actually happens. Making sure that the platform is encrypted and HIPAA compliant is certainly important. And one thing to remember is that just because the platform is HIPAA compliant doesn't mean the interaction is HIPAA compliant. So making sure that the clinicians are still keeping in mind everything that goes into being HIPAA compliant. And so this is just one component of that. Many of the platforms have chat features as well. And so these are nice options to troubleshoot. If someone's having a hard time logging on, but they can see the chat feature, that's one way to talk back and forth. It also provides opportunities for just quick information sharing. And so what we find a lot of times is folks will respond to text messages and just chat features more quickly than they will email or even a phone call. And so this is another way to stay integrated with the individuals they're serving. All right, so I have a quick question that came through.
It's just about HIPAA. So one of the biggest pushbacks that I see here is potential violation for HIPAA. So I know you touched on it, but if there's any way they can get over that barrier.
Yeah, so the question was on violations for HIPAA. And really, there's a couple ways to do that. One, we talked about the technology platform, making sure that it is encrypted and HIPAA compliant. The other way to do this is making sure that therapy is occurring in a private environment. And so the use of headsets is a nice option, and even cubicles and that sort of thing could be an option, provided you have a headset in place and a lot of the visual of the screen is actually avoided from other folks. So those are a couple ways. And then really just educating your clinicians on what do you talk about and what do you not talk about in front of other people. And those are all some of the standard HIPAA compliant practices that they should already be practicing. So certainly some nuances to this, but we haven't found it to be a big challenge up to this point in time. One other consideration as these folks are going out into the community, it is really important that this therapy is mobile. And so we're going to be talking about the hardware necessary, but when the individual is out into the community, making sure that those conversations remain appropriate, and then the use of wireless headphones on the client side also allow for some privacy there too. And so those are just some other considerations. And then, of course, there's consent forms and that sort of thing that needs to be initiated prior to services, and all of that is a nice safeguard as well for HIPAA compliance. So moving into the hardware and technology, we want it to be accessible and convenient. And for us, using phones and tablets has been really the best option. Certainly it can be accessed through a computer, but that really does confine someone to their home or to even a single room within their home. And sometimes that's great and okay, depending on what the therapy plan calls for. But the phone and the tablet allows for really great mobility. But in order to do that, a cellular data plan is also essential, because not everywhere has Wi-Fi that's available in those areas. And so making sure that the cellular data plan is set up in a way to allow for video conferencing, and that the data plan is big enough for the amount of data being used. I've already alluded to the fact that wireless headphones are a really nice option here. It provides, private conversation, but it also provides hands-free conversation for these individuals who might be out in the community, going to the grocery store, or even working out at a fitness center, so that we can provide feedback for this individual that is also private. Device mounts and equipment is something else to consider. Again, this doesn't do us any good if someone has to stand in the background holding the device, and we have to utilize a person for that. So a device mount avoids the need for that. It also avoids the need for the person to actually hold their phone or tablet while they're doing an activity. And so making sure that the device mount is cost effective, but also effective in maintaining the weight of the phone and the tablet. And it's also versatile and can be placed and attached to different aspects of the person's environment. So that's something that has been a really fun challenge for us to figure out what are some of the most versatile mounts we can find and what types of equipment is best for these individuals. And then lastly, remote site requirements. I'm not going to go into this a ton, but here's just a couple things that we've had to consider. We have to obviously have a working microphone and camera and speakers on the receiving end, and the the clinician side. So certainly those have to be in place. And honestly, a lot of the challenges have been on the client side, because our technology is obviously up to date and ready to go, but their device and their software might be running on a out of date version that doesn't support the platform. So making sure that all of those are up to speed and fully updated, and the patches and antivirus software isn't getting in the way of things. And so there's some legwork that needs to be done on the front end for that. Another obvious one is just internet access and bandwidth, making sure that it's capable of supporting the device and the video calls. And certainly this is more of a concern in rural areas, but if you had someone who didn't have access to cellular data for some reason, or was accessing their broadband from their home that wasn't up to speed, then that would pose some experiential challenges for these individuals. A few clinical principles to just keep in mind. The preparation is really key in this area. And not that the preparation isn't something that's important when you go see someone face to face, but when you're not prepared in this situation, it's a bit harder to think on the fly and to implement services on the fly. And so our clinicians have really had to bump up their level of preparation and making sure that they have everything that they need on the front end, but also making sure that the client has everything that they need on the front end. And so being more proactive and planning a couple sessions out rather than maybe session by session, and having a clear vision of where that's going to go. Camera orientation, again, making sure that the lighting and the sound is appropriate on both ends. Having TVs and things like that in the background can really provide some challenges from an audio perspective. And even lighting, so making sure that the lighting doesn't provide a shadow, and so that you can get a clear picture of of each side, so that you can objectively measure things and that you can see really clear, detailed what's going on. So just making sure everyone's paying attention to the camera orientation and the environmental considerations that come with that. The technology training, again, many of our folks are pretty technologically savvy, but even in those situations, you have an issue with an updated computer, or maybe they have their microphone off, or there's just a small piece of this on their end that is posing some difficulties for them accessing the technology. So making sure that there's training up front, and then also making sure that clinicians and IT is available to do some real-time troubleshooting. So our clinicians have had to really get good at troubleshooting alongside the client, so they don't have to pick up the phone and call IT every single time, because we don't need to be dropping sessions or making sessions that should be an hour into 45 minutes because we can't handle our technology. And so making sure that we're being proactive on the front end is really, really important there too. So really, what we're trying to do is connect therapy to life. And as I've mentioned, having a meaningful and individualized and engaging therapy within the client's environment is really the goal. So what I wanted to do is end with outlining some options for how you could implement this therapy. From an occupational therapy perspective, here's a few things to consider. So daily living skills training, and so things like toileting routines, dressing, and cooking are really nice options. And this certainly isn't all inclusive, but we've had examples where someone has challenges with accessing the restroom, whether it be in their home or in the community, or even their routine requires some maintenance or some rethinking. And so these are areas where we can jump in and observe really what's going on and what are some of the challenges with that. And then beyond that, we can provide some recommendations and resources as to how to move this forward. And so this could be paired with different adaptive devices that might be necessary, or some more traditional therapy related tasks like strengthening and mobility and that sort of thing, to make sure that the person is successful in their routine. Same thing with dressing and cooking. On the cooking side, it could be the use of adaptive devices, but it also could be simply planning and organizing a meal and making sure that the individual has done what they need to do as far as shopping and a grocery checklist and that sort of thing. And so, that kind of leads into the daily planning and organization. And so if someone's not planning well and organizing well, their day isn't going to be as smooth as it might be if they were effective in doing that. So that could be helping them in particular plan and organize, or it could be consulting with their aides and their network to make sure that they're being supportive and making sure that that's being done in the right way. Environmental accessibility and adaptation consultation. So this is simply how accessible is their environment, and that could be their home environment, that could be their work, that could be the fitness center that they're going to, anything that the individual would have to go to and access. Those are situations where we can jump in and provide resources and provide recommendations on what might be helpful or areas to avoid and that sort of thing. One thing that is a bit challenging is driving. So this would be a situation where I don't think occupational therapy would be a great option other than maybe an initial screen. But a lot of those types of situations do require some hands-on therapist interaction. So that would be more of an area that's gray, but would probably land in a face-to-face interaction. Adaptive devices and DME recommendations. Again, we've kind of hit that with the daily living skills training and that sort of thing. But, as these folks transition out into the community, what we often find is they continue to progress. And a lot of times their abilities are above what their DME recommendations are at the time. And so this often requires some updating and some changing. And then fine motor training, upper extremity strengthening and training is another option for these individuals. Speech therapy. This one, again, is pretty straightforward. There's a lot you can do face-to-face through the camera as far as expressive and receptive speech intervention. So making sure that these individuals have the strategies needed to communicate. And if it's an expressive issue, are they using the right AAC device, or have they developed other strategies to communicate with the individuals in their network? And then even with that, how well are they executing those? Because there's a difference between practicing that in a formal therapy session and actually seeing it happen in real life. And so again, the value of this is that the individual could conference in and we could observe an interaction with them and make some recommendations and help facilitate that, and even help the receiver on the other end with some strategies to help promote really good communication. Receptively is the same thing. What types of things do they need to do to make sure that they are receiving the information appropriately, and what does their caregivers or their coworkers and that sort of thing need to do to make sure that speech is happening in a way that's effective. Executive functioning, things like attention, memory, problem-solving, awareness, and safety are all areas that we can address. Again, being in the moment and real time with them to make sure that they are making good decisions and that they're problem-solving through novel situations. Again, a lot of these situations don't come up when they travel and go to a brick-and-mortar therapy clinic. We can talk about them and we can say, hey, if this situation comes up, if there is a fire at your home, what would you do? But that translation into actually being able to do it is a big jump. And so if we can be in the home and walk through those steps and practice those steps in the home, a lot of times it's more effective. And then life skills training, so social skills, the planning and the organization. Again, this came up on the occupational therapy side. And there are lots of opportunities for this and lots of areas where there is crossover. And so for us, when folks are saying, hey, they're struggling with social skills and planning and organization and budgeting, certainly that could fall under a speech therapist's scope of practice, but it could also fall and cross over with our occupational therapist. So a lot of times we're asking those questions of, when is this happening? What types of situations are they running into, so that we can determine which clinician is best. But at the end of the day, if we can provide opportunities for them to have better social interactions and make sure that a lot of those life skills are in place, or at least moving towards them, and they can take more ownership of them, then again, they're more engaged and more actively involved in their therapy. exploration of purposeful daily activities. So examples of exploring volunteer options and making sure that these individuals have something to look forward to within their day. So as an example, we've been working with some folks to figure out what are you going to do within your day, and have been able to uncover some nice volunteer options, such as going to the YMCA or helping out at the local nursing home and that sort of thing. And so in those situations, we're not only exploring those, but coaching them through how do you actually go and propose that you could be a nice resource to them. And then once you're in the situation, how effective are you, and what sorts of things do we need to put in place to make you successful there? And so there's some collaboration with those other entities and making sure that they're on board with this and know exactly what they're getting into, and making sure that the person can integrate into their environment and make sure that they're successful. So again, a really nice option and a really mobile option for speech therapy. Physical therapy, so gait and functional mobility training and endurance. A lot of this could require the use of a caregiver, certainly, and making sure that that person is available and is capable of spotting or providing some feedback for these individuals. But it is relatively easy to help them and coach the caregiver through a lot of those tasks and activities. And so making sure that we provide appropriate activities from a training perspective, but then also providing the right amount of support and almost verbal coaching to both parties to make sure that they're able to effectively complete the activity. And it's things like bumping up their endurance and providing opportunities and brainstorming, when could you walk more, or when could you go out in the community a bit more, and making sure that there are resources in place to access that. And so, an example that we've had is taking someone out into the backyard and navigating their stairs down and up from their deck. And then in the backyard, obviously, that's a great opportunity for some balance training and uneven surfaces and that sort of thing. And so there's really opportunities within the person's environment. The clinician does have to get pretty creative and making sure that there are opportunities for that within the environment, or if they're not, what other resources do they have? So is there a fitness center in their apartment, let's just say, or do they belong to a local gym that we could utilize, and making sure that there are resources there that we can either consult with, or can we be brought into that and actually provide the therapy in those settings. And then again, community access, this is another area where it crosses over with occupational therapy. But we have lots of folks who, their caregivers maybe aren't confident enough to bring them out into the community without a wheelchair, let's just say. And so that requires quite a bit more planning. It's not as convenient for them if they have to take the wheelchair. So can we help them envision what it might be like if they didn't take the wheelchair? And how could they get around having the person ambulate rather than use that type of mobility, because it's really going to lead to just greater access. DME assessments, again, another crossover with occupational therapy, but specific walking devices, canes, walkers, even some wheelchair assessments that could be done both by PT and OT. Again, the wheelchair assessment is an example of something that might be better done face-to-face, but we can at least do a screen, and we can at least provide some upfront ideas as to what might be needed to promote better positioning, troubleshooting, that sort of thing. So there's a lot that can be done virtually there, and we can always make recommendations to go in a different direction if we need to. And then lastly, psychology. This is one that's pretty widespread already and being done quite a bit telephonically, but making sure we have a good example, or a good idea of the family dynamics and social relationships. We've been in a couple of situations where, the family, as we've done a screen or an assessment from a psychology perspective, the family's saying that things are great. And until we dig in and our other clinicians get in a little bit more and understand what's going on, we don't uncover that until we do that. And so what we found is if we can initiate some PT, OT, or speech, a lot of times the psychology comes after the fact, especially in the situations where the family is saying that things are going well. And so we can start to uncover maybe some concerns with complacency, or some concerns with where they're going to go and what the vision might look like. And so we can help and jump in as needed. And certainly the emotional coping and recovery definitely is in line with that. And there's a piece of skilled therapy and cognitive behavioral therapy as an example that can be done, and making sure that we are a resource to these individuals as they are continuing to progress through their injury, and helping them with some more healthy thought processes, and even being an opportunity just to vent and say, gosh, here's what I'm having a hard time with. So again, all these are pretty straightforward, but having someone who's skilled and understands brain injury and spinal cord injury, I believe is a gap. And if you have a clinician who doesn't understand them, the way they present information, and even having some empathy towards what they might be going through, is going to be lacking. And so having someone who is trained in neurological injury, or has at least dealt with these individuals, is a nice option. And then mindfulness and self-awareness. This is certainly something that is becoming more prevalent, but this is an area where you can do a nice guided meditation, and you can work on some self-awareness training, and this translates into success within all of the other disciplines that we've been talking about. So again, a nice option that can be guided and scaled up or down depending on the level of need and the level of access, but it is a really nice option that promotes engagement and self-accountability on the client's end. So with that, looks like we have some questions that came through.
Yeah, we do.
We got quite a few questions that came through, so I'll try to work through some of these since we have a little bit extra time.
I'll read them off here. So just wondering about state regulations involved. So based on your research, are there any state regulations that prevent QI from providing telerehab services across state lines? If you want to touch on it.
Yeah, the licensure is certainly a challenge. Right now, just to give you guys an idea, QI is licensed in 26 different states to provide these services. That comes with a caveat. We're licensed with physical therapy, occupational therapy, and speech therapy primarily. Psychology has been a bit more challenging across state lines because their compacts and their regulations for licensure are a bit more stringent than they are with physical therapy, occupational therapy, and speech therapy. So with those first three, we've been able to leverage some compacts within the states that allow you, if for physical therapy as an example, there's a compact that includes a number of states. So if you're licensed in Nebraska, that also means that you're licensed in a handful of other states. So it makes it a little bit more easy and more streamlined. And then at the end of the day, it's really just keeping track of the paper trail and making sure that there are that our clinicians have the right continuing ed in place, but also making sure that we're keeping up with maybe some state-specific guidelines as it relates to telerehab and what is and is not allowed in those states. So we've had to really beef up our knowledge in those areas.
Question about initial PT evaluations. Are they being performed via telerehab? Is there any certain level of complexity where this may not work?
Yes, they're being performed through telerehab, but where they don't work is if there is safety concerns, for sure. If there's a need for some really hands-on evaluation, and obviously the clinician can't put their hands on them in those situations. And so in those situations, we're really encouraging the individual to go to someone face-to-face. But honestly, there is a lot that you can do, and the way our clinicians are trained, they're very much observers of movement, and they understand what's good movement and what's not good movement. And so that's very easy to see over video. And so as long as the camera is placed in a good spot so that you can see the entire environment, and as long as you've developed the right activity to observe what you need to observe, then it's certainly doable for quite a few situations. There's just those types of situations where our clinicians are having to use clinical judgment and saying like, yeah, I can't make a good clinical judgment here, and so we'll have to go a different route for that.
While we're answering this next question, I'm going to pull up the poll question. So remember, this poll question you do need to answer if you're looking for a CEU certificate. That's going to be up on the screen now. And then Steve, while that is going up, if you could touch on, are there any documentation considerations for therapists to ensure coverage? This is tied to a question around reimbursement, billing, those types of things.
So What I can't answer is how the documentation affects like commercial health insurance and Medicaid and Medicare. We haven't tackled that. But as far as documentation goes related to workers' comp, we are doing a lot of documentation very similar to how we do on the inpatient side. So making sure that we are providing a really clear idea of what has been assessed, also a really clear idea of what the plan is, and then a really clear idea of duration and frequency. And so those are all tied together. Now, what I think that does is it holds our team accountable to say, hey, we have a good vision for this program, but it also says to the payer, like, hey, here's what you can expect as far as an outcome and how long it's going to take, and then you can start predicting how much it's going to cost. Certainly in between the time of assessment and the time of discharge, there needs to be some communication in place, and that can happen in the form of just daily documentation, SOAP note style. I think is sufficient, but also if there needs to be some more upfront communication or more maybe phone communication along the way, I think that's certainly an option. And then on the back end at discharge, making sure that we have a clear idea of what was the current status and what progress was made, and then having a clear idea of what the plan is moving forward should they be discharged and transitioning to a different level of care. So I don't think it's much different than what you see traditionally. Just making sure that the communication is high and making sure that we're really able to paint a clear picture of what the abilities are, what some of the barriers might be, and have a good plan for where we're heading.
There's a few questions about costs. One that I think you can touch on in the webinar would be who is responsible for the expense of equipment for telerehabilitation on the client's end, such as purchasing camera, accessing Wi-Fi. Is this the client's responsibility, or do insurances cover these expenses?
Yeah, this is, again, I'll answer this from the perspective of workers' comp because that's where our most experience has been. And really the approach we've tried to take is that we want to minimize as many barriers as possible. And we believe that one barrier is that if we provide the client the opportunity to get all of the hardware in place, that's a potential failure point. And so what we've done is worked in the cost of all of the hardware, the cellular data, and all of that into the upfront cost to initiate services. And so that is a lump sum, and that's something that we're working out with the payer ahead of time, and that would be a cost to the payer. Now, as we transition into private pay and other forms of insurance, I think that that's going to be something we're going to have to figure out. And I think the cost of devices and things like that, let's just say in a private pay situation, is going to be transferred to the client should they have interest in participating in this therapy. But what that does is, I think, bumps up the need for training and a really solid IT plan to make sure that when they purchase their equipment, and making sure that they purchase the right equipment, or if they have existing equipment, that it meets the specifications that are needed. And so making sure that we have that sort of troubleshooting and level of resources available to make sure that the experience is good. And so I think it's going to differ depending on who the payer is. I don't know where it's going to land when it comes to Medicaid, Medicare, and commercial insurance. If I had to guess, my guess is that they're not going to pick up the costs of that. The work comp carriers that we've worked with just understand that the value of having an upfront turnkey option is a really nice option, and they've seen value in that, and is something that they had really, in a lot of ways, planned on purchasing anyway for other reasons.
Let's see here. There's one about outcomes.
Thank you for someone who noticed my spelling.
It was actually my spelling.
Oh, that was Tim's spelling.
It's mine on the poll question. So don't blame that on Steve. That was on me.
That wasn't me. I'm only in charge of the PowerPoint. So if you see anything on there, let us know.
That's definitely
that was mine. Tim.
What outcome goals are and are not appropriate for telerehab referrals?
Oh, that's a really hard question. Gosh, that's, I guess the reason I'm hesitating on that is just such a there's so many variables to consider. I guess I would go back to what's the level of support available. Have you considered, and do we have a good idea of what the person's abilities are? Again, I think if the person is living independently or is in a community-based setting, then I think that should at least trigger, is telerehab an option here? That's the first and easiest situation. If it requires, if it's heavy gait training that requires intense equipment, then, ambulation might not be an appropriate outcome goal for that. But if it's someone who doesn't require that type of equipment and either has some support or it's really more nuanced, then I think that is an option for telerehab. So I guess in a lot of ways it just depends on the scenario. But like we do on the inpatient QLI side, we're looking at the whole picture here. What is their psychosocial history? Is there a big history of mental health? And if there is, what's that going to do to their level of compliance and that sort of thing? At the end of the day, we're all partners here, and so we try to make recommendations that are going to be a good use of everyone's time, energy, and resources. And again, that includes financial resources. And so, we'll do our best to say, like, hey, here's what we think we can do, but here's going to be some factors that might pose some challenges, and make recommendations when we don't think it's a good idea. I've already had at least 2 situations where I've said, you know what, we'd love to help you, but we think you'd be better served over here, and it ended up landing in a more traditional clinic setting. And so I know I kind of danced around that question, but it's probably not as black and white as just saying here's an exact diagnosis or here's an exact situation that is good.
In workers' comp, a lot can be determined by how a client presents. How do you get that kind of information via telemedicine? So I think more just on the assessment.
Yeah, so this seems like an assessment question for us. We balance that with the in-person assessment, and so that's why we've chosen to do that, because we feel like we want to get a good picture of what the person's environment looks like. We want to get a good picture of what their support system looks like and how do they behave in their environment as well. And so that in-person assessment for us, at least at this point, is key, because we don't know if that's going to absolutely be needed long term, but as we're starting this, it's something that we've committed to. And then I think, believe it or not, there's a lot of research saying that the connection via video conferencing is at least as high, if not higher, compared to what it is if someone's in person. And the research says that, a lot of it has to do with eye contact. A lot of it has to do with the fact that the clinician on the other end is even more dedicated to that person being one-on-one, rather than being in a clinic where there's, maybe they have 3 or 4 other people that they're seeing at the same time. And so they end up getting a better and more engaging experience from the clinician. And so for us, we haven't had much of an issue connecting with the client virtually. And then the assessment, certainly, again, the hands-on assessment is a challenge, but leveraging their network and their support system on the other end is a nice option for us.
One other question, Steve, around the follow-up. So do you follow up with house visits to check essentially just what does the follow-up look like after sessions or after the telerehab program is finished?
Good question. I mean, I think that's still to be determined. We're still in the beginning stages of this, and so we have initiated some sessions with people, and we have some programs actively going. The discharge from that is, I think, going to depend on the situation. If we do need to go back out and visit for some reason, I think that's something that we would consider. But I think the idea would be that once we've gotten a good handle on what's going on, that we can get most of what we need virtually. So that would be the goal. But if there is a reason to go back out and observe, or if there are challenges that we're running into as far as effectiveness, and it does require an on-site visit, that would be something that we would consider. At the end of the day, we want this to be a good option for everyone, and we'll we do what we need to do to make it work.
And I think that's it. That's all the questions we have right now. If you didn't see the poll question pop up, we had a few people that said they didn't see it. Just reach out to us directly at qlibwebinars@qliomaha.com and let us know that you didn't see that, and we can make sure you get the certificate. Please check us out at qliomaha.com. We've got some cool stories on our blog about some of our residents that have come through our program. So any information you need. And then if you have any questions, Steve's contact information is up on the screen. Feel free to reach out to him directly. There's a few folks that did ask some questions that I will direct to him that he can answer offline. And I think that's it. We have
One other thing I would say is if you do have questions on specific people that you're serving, I would be happy to answer those too and dig in a little deeper. I know there were a couple of questions that, again, I had to answer at a high level, but certainly open to discussing them and figuring out if telerehab is an option.
Yep, and then be on the lookout within the next couple hours. It'll probably be a little bit longer than usual today, so probably the next 2 to 3 hours you should be receiving your follow-up email with a certificate and an evaluation to complete. Again, you do have to complete that evaluation to receive your CEU certificate, so be on the lookout for that. And then also we'll see you next month. We've got another webinar coming up on March 20th. It's more of a higher level brain injury education course. So thank you for joining us, and we'll see you next month.